Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr. Travis Brown. This is the story of thyroid lumps, part 2. Professor Yuri Nikiforov is the director of the Division of Molecular Anatomic Pathology at the University of Pittsburgh School of Medicine. He received his medical and doctoral degrees from Minsk Medical Institute in Belarus and completed anatomical pathology residency at the University of Cincinnati and postdoctoral fellowships in pathology and endocrinology at Brown University and Cedars-Sinai Medical Center. Professor Nikiforov's clinical interests and expertise includes the pathology and genetics of thyroid cancer, having authored more than 250 peer-reviewed articles, more than 10 chapters. He is the senior editor of the popular textbook Diagnostic Pathology and Molecular Genetics of the Thyroid, as well as receiving the prestigious Van Meter Award from the American Thyroid Association. Professor Nikiforov's current research is focused on the identification of novel mutations in thyroid cancer using next-generation sequencing and the application of molecular genetics of thyroid cancer to the clinical management of patients with thyroid nodules. Professor Yuri Nikiforov, along with his wife and Professor Marina Nikiforov, have developed the test ThyroSeq, next-generation sequencing for thyroid nodules, and Yuri is our special guest on This Medical Life podcast. Yuri, welcome.
Thank you.
Let's just go back to the history first. When did you first become interested in thyroid pathology?
I was actually pathology trainee. I was a resident in pathology at Minsk Medical Institute when Chernobyl happened. And after Chernobyl, I still was in training, and we were expected to choose a field of interest, field of study, and I felt that maybe I should specialize and develop more interest in thyroid. And then a few years later, when I was just a young assistant professor, we started to see increase in incidence of thyroid cancer in children. And that's kind of solidified my interest in this subspecialty of pathology.
How far did you and Professor Marina Nikiforov live from the nuclear disaster of Chernobyl?
We lived in Minsk, which is maybe 354 kilometers from Chernobyl. But Marina's parents and her family, they lived in Gomel region, which is about 100 kilometers from the place of the reactor, and they were really very severely affected by this accident.
Now, the disaster itself, there wasn't much information coming out from the government at the time. Did you know the risks of what was going on then?
Well, to say that there was not much information was even too much, because it was not a lot of information. There was no information. So just after the accident happened 5-6 days before the 1st of May, which is a big communist holidays, where we're supposed to go march and say how much we love the Communist Party. So it was strictly, there was no any information about the accident until the May 2nd, when all festivities and all demonstrations were over. So the very, very valuable time to protect population was lost because of the political reasons.
When you started to see the incidence of thyroid cancer, did you know then that, well, first of all, that this was something very odd that was going on, and then link it through to the disaster?
At that time, I happened to practice as a young pathologist, practice in oncology center in Minsk, in Belarus, pediatric oncology center. And Belarus is a relatively small country. It's just only about 9 to 10 million people. And there is one large pediatric center. So advantage of this is that for rare diseases where most of the patients come, and I can tell you that thyroid cancer in children is a very rare disease. average incidence, in the world is less than 1 case per million children per year. So really, all these years before, we had at that center treated maybe 1, maybe 2 max children with thyroid cancer. And then in 1889, only 3 years after the accident, we saw 22 cases. And we said, so strange. And most of these kids were coming from that place not very far from the accident place. And it was we started to talk between us, but we were not sure. Then in 1990, we started to see like 55 cases. So we went from 1 to 55 cases per year. And again, and at that point, we really realized that it is very likely to be associated with the accident. We tried to talk to our superiors, and they said absolutely no information. They said under no conditions you can draw any associations between the accident and this cancer. That's that's what was the very disheartening for me and for many of my colleagues. But at that time, it was little doubt because it was such a huge increase. And most of the children were living not so far. They were mostly from Gomel region, from Mogilov region, from Brest region, actually that are bordering the Ukraine and the place of the reactor.
Just 2 aspects to that. I'd like to know how young some of these children were that you're talking about, and also in relation to the government trying to not say anything. If it had said more, could more things have been done to avoid some of the excesses of this impact?
I can tell you, Steve, that these actually questions are related to each other. Okay, in what ways are related? We started to see this increase in 1889, 1890, which was only 3-4 years after the accident. And part of the reason why nobody believed that of such association was that all previous knowledge from Hiroshima and Nagasaki atomic bombs, from some X-ray therapy for children for cynomegalies, that the all knowledge suggested that you need at least 10 years for radiation-induced thyroid cancer to develop. And in this situation, we have only 3 to 4 years, and we already started to see this increase. Okay, so now it brings us to your second question. So why we saw this increase? And this is the answer. In young children, thyroid gland is the most active, and thyroid gland make thyroid hormone. And this hormone has iodine in it. So this gland itself like a vacuum cleaner, just sucking the iodine from blood. Okay, and one of the main isotopes, short-lived isotope that was released after the accident was radioactive iodine 131. Okay, so these children were particularly susceptible. They accumulated much higher dose than older individuals. And I tell you even more, the younger the age was, the higher the dose they accumulated. So basically, we started to see this in 89, 90, 91, and most of them were very, very young children. These were children that were born just before the accident, who were less than 1 year old, 1 year old, 2 years old at the time of the accident. And with the older they were, the lower the risk was for them to develop thyroid cancer. Okay, and now directly to your second question, you said, could this be preventable? If I tell you that many of these children were babies, were 3, 4, 5 months old babies at that time, then what do you? So how do you think that iodine get to those babies? How they ingested iodine? How they ingested? With mother's milk. Okay, and with cow's milk. Okay, so, and now here is the thing. Iodine 131 has 8 days half-life. Okay, 8 days. It means in 8 days, it's half of them is gone. So all the government needed to say, people, there was an accident. In the next 16 days, don't drink milk from cows, and don't take your babies and children outside, keep them indoor. Only these 2 measures would save 95% of all this. You didn't need to take the stable iodine. You didn't need to evacuate. You didn't need to go through some extreme measures. All you need to do is not to drink milk and not to play outside. That's how easy it would be to prevent thousands and thousands of thyroid cancer if you care about people and not about your political bosses.
With the cancers being so rare, do you remember what type of cancers with thyroid you were seeing? Were they all sorts, or was it one particular type of cancer?
Virtually all thyroid cancers develop at the beginning and develop during the whole kind of this, lifetime in these individuals. This is a papillary thyroid carcinoma.
Given that the information was not freely available, and even at that point you were saying you can't link this, your superiors were saying you can't link this through, how was this really rare diagnosis, or how was this frequency that you were seeing confirmed?
Patient develop cancer, and the children that develop cancer, and usually in children particularly, it goes to a neck lymph nodes, and probably parents, palpate these nodes, take to physician, they look, suspicious, they send to oncology center, oncologist stick a needle into the nodule, send it to cytology lab, and we look and we said, okay, this is papillary carcinoma. So it is diagnosed not differently from how it diagnosed in non-exposed individuals. The difference was that it was much more common in the population as compared to the time before Chernobyl.
Was there a study where external pathologists came in to say this is actually related to that, and that was how the information was disseminated that it was linked to?
It was a little bit more complicated than that. But so you see, when finally in 91, after the sort of collapse of the Soviet Union, when sort of, at least one layer of political oversight was, off. So the government started to talk, of Belarus started to talk, yes, that there is this cancer and so on and so forth. And they actually published a very small paper in Nature, in the Journal of Nature, saying that this is an increase. It was under 1 case per year. Now we have 60 cases per year. And from that region, it's likely related. In the same issue, there was a column, the reply from the international, a panel of international experts. The top expert in the United States, top experts from Italy, top experts from Great Britain, who were saying, no, it cannot be thyroid cancer. It cannot be. And I want to step back, look, and you say it diagnosed by a needle, then they send it to surgery, they removed it, they remove, and pathologists look and say it's papillary carcinoma. So it's very obviously, but in that paper they were saying, no, this cannot be radiation-induced cancer. Why? Because all we know from previous accidents and like again atomic bomb explosion in Japan, that it takes about 10 years, and this is only 5 to 7 years. So it cannot be. So probably those people in Belarus pathologists, they just don't know how to diagnose cancer. They probably misdiagnose and overdiagnose, and so it cannot be. And they sent a delegation, and then they had 5 people from all over the world, and 2 endocrinologists, 1 endocrine surgeon, 1 pathologist, and I think 1 radiologist. They come, and I was there. I remember it very well. It was probably 1992. They come to Minsk, and the pathologist on that panel was Sir Dilwyn Williams from the United Kingdom, who, one of the top endocrine pathologists. And they come and he said, give us all cases. And we bring this trace with slides. And he looked at 55 cases, and he confirmed the diagnosis in 54 cases. So one case that he changed the diagnosis. And then they published another letter a few months later saying that, actually it is indeed papillary carcinoma. It is indeed, and the clinicians went to the hospital and examined those children. They were verifying. They thought that maybe people don't know, didn't know what they were doing, but we knew what we were doing. And then they published a letter saying that it's likely related to the accident. So that's how it all, evolved.
Now, this planted the seed because later on you would actually move to the United States. How did it come that you became into genetic pathology and started doing testing for thyroid cancer?
I told you that I was at that time a pathologist in this pediatric oncology center, and I knew that this is terrible tragedy, but this is related to the accident. And as a physician, as a scientist, at that time I already was involved a little bit in research and science. I was trying to tell my superiors, look, we need to study this. This is a horrible experiment that, created on people, but we need to study this. We need to understand how it developed. What is the mechanism, how this exactly developing. And that was a very, very early sort of era of molecular genetics, when we started to understand the genes and chromosomes and how cancer developed. And you know what? I don't know how much you and your audience know about pathology, how we process. Surgeon removes thyroid gland and send to the pathology lab. Pathologists slice it into pieces and take representative, most abnormal looking pieces to study microscopically. And the rest of this material is usually kept for a couple of weeks until the pathology diagnosis is issued, and then discarded. And I was trying to tell people, we cannot discard it. This is a crime to discard this, because we need to study. We need this tissue then to study genetically, to understand how it works. And they said, nope, you cannot do this. You cannot do this because we don't have, we don't have an order from the government that you cannot do it. And I can tell you, I started to collect this material by myself. When they were throwing it away, I was taking it back and I was hiding it. And I was collecting this material because I felt that this is impossible to discard it and not to eliminate our chance to understand it. And then I built, and I was paying from my own money, I was paying the laboratory technicians to embed this tissue in paraffin, to prepare paraffin blocks, because that's how you can preserve this tissue. And then I accumulated a collection of about 40 cases of young children with this. And I wanted to study it. And I started to write letters all over the world to thyroid scientists, asking them to, invite me, to allow me to come and study this in their lab. And I can tell you that I wrote exactly 44 or 45 letters, and I received one answer. I received one answer from the United States, from Brown University, from a pathologist, Dr. Douglas Knapp, and he invited me to come and study genetics of this disease. And that's how it happened. And then I was just lucky to have a chance to do it.
I lived in Hungary around the time that this was happening for you in 91, 92, 93. People in the West don't understand what it's like to live under those sorts of political regimes. Just could you reflect, was it a feeling of fear, or was it a feeling of just frustration from the bureaucracy?
I think it's both. It's both. Because there's definitely, I can tell you, there was a feeling of fear. Because communist regime is a terrible, terrible regime. Democracy has a lot of problems, but it cannot be compared with a truly terrible. They can do anything with you, they can do anything with your children, they can do anything. So there is no protection. So of course, there was always an element of fear. But there is also some kind of internal feeling that no, you want to prove them wrong. You want to do how you feel your heart, you want to do. There was a fear, there was a frustration, but there was also determination. I could not. Yes, I probably took some risk, maybe more than some risk, but I still felt that I have to do it. I felt that it is my duty, that it is my responsibility being part of it to try to not to get it wasted.
We return now with our earlier guest, Dr. Tiffany Symes, who is a histopathologist and Deputy Director of Anatomical Pathology at Melbourne Pathology. Tiffany, welcome back.
Thank you. Nice to be back.
What are the common malignancies in the thyroid and how common are they?
Yeah, so look, I think probably putting in perspective to think about all thyroid cancers as a total number first. So in the Western world, the incidence of thyroid cancer, just as a general concept, is about 13 people per 100,000. So that equates in Australia to about 4,000 people a year diagnosed with thyroid cancer. If we then break it down and have a look at the more common types, probably the two most common and that people might have heard of are papillary carcinoma and follicular carcinoma. Papillary carcinoma is by far the most common. About 80% of all thyroid cancer cases are papillary type. About 10% are follicular type. And then there are three rarer subtypes that are probably worth mentioning. Medullary carcinoma, about 6%. Oncocytic carcinoma, about 3%. And then anaplastic carcinoma, about 1%. And then there's a additional subset of very rare things we don't need to talk about today.
So when we're looking at a report, clearly we're sort of almost wanting to focus on the general practitioner perspective. When they're actually looking at the report, because we now report a whole bunch of structured reporting, a whole bunch of fields, what's kind of the most important part for a general practitioner to focus in on?
Ooh. I was going to digress a little bit here for a moment, Travis, if I may, and just give you my perception of what I think about a histology report, just in general, so not with related to thyroid. I consider the histo report as the outcome of a specialist medical referral between usually a surgeon, but between another clinician and a pathologist. So that report is like the letter that you get back. As a GP, you get a letter back from the surgeon after you've referred a patient. So that report to me is like our letter to the surgeon or our letter to the GP. So from my point of view, I consider what do I need to put in that report for the clinician to help them with the diagnosis, the prognosis, what to do next, what to tell the patient, and also whether or not there's anything they want to follow up with somebody else. So they're the kind of that's the background to what I think are the important points for a thyroid, for a histopathology report. When it comes to thyroid, I think it has to have an integration of the clinical and radiologic features as well as all of the histopathology features. So we try to integrate all those things. And similar to, you were talking about structured reporting before, similar to what we do with other cancers, we generate a structured report with a whole series of information in it. That report includes a macroscopic assessment of the thyroid. Now, that's important to correlate to the radiology. Did the radiologist, what they saw and what they thought they were sampling, did we see that in the sample, and is that what we've examined? So we'll provide metrics around the abnormalities, what it looks like, how big it is, etc., as part of a macroscopic assessment, and that's really important for that correlation. And then the microscopic examination probably is really the crux of it. That's the bit that we're looking at as a specialised pathologist down the microscope and providing that data. So I think the diagnosis is absolutely paramount. Any features that affect the stage or prognosis for the patient. So things like size, certain subtypes, whether it's invading the vessels, whether it's invading outside the thyroid, whether it's invading through the capsule of a lesion. That's the kind of information that I think is important in the micro. All of that information is then put together to stage the tumour. So I think for the GP, it's looking at the bottom line of diagnosis, any of those prognostic factors which will affect the patient's potential longevity, and then the stage. And they're the things that are going to inform follow-up and further treatment.
So when we're thinking about the diagnosis you mentioned, just probably focus in on the top two, so papillary and follicular. When we're looking at papillary, what is the prognosis that we're looking at for the general population for these patients?
Well, papillary carcinoma actually has an excellent prognosis. We're looking at a 5-year survival rate of about 97%. And in fact, because papillary forms the majority of thyroid carcinomas in the population, the 5-year survival rate of thyroid cancer overall is well above 95%. Follicular carcinoma, the prognosis varies depending on what type. Now, there are a few different subtypes, if you like, of follicular carcinoma, and each of those potentially has worsening behaviour according to some qualities they have. And so those prognosis varies. So for a 5-year survival rate of the least aggressive subtype is also very good, 95 to 97%. But the most aggressive subtype of follicular carcinoma has a 5-year survival rate of about 45%. So it's variable across follicular carcinoma, depending on the subtype.
Which one's fitted to which category? Which is sort of the follicular best prognosis? What name do we give that? And which is the worst? What name do we give that?
Within follicular thyroid carcinoma, probably the best prognosis is the minimally invasive follicular thyroid carcinoma. This is a tumour that arises, originally would have been an encapsulated adenoma, so a benign lesion with a fibrous capsule around it that's sitting in the thyroid, not doing anything bad. It ruptures through that capsule and becomes malignant. But minimally invasive is one that down the microscope we can still see the remnants of that adenoma. So there's a capsule left, the majority of the lesion looks encapsulated, and there's areas where the tumour has ruptured through the capsule and is now invading into the thyroid parenchyma. That has the best prognosis. There's a subtype in between that and widely invasive, which has the worst, called encapsulated angioinvasive. It's actually relatively new. It's only been in the classification for a year or two. And that's one where it's also got evidence of the encapsulated lesion, but it's now not just invaded the capsule, but it's also invaded into the veins. So we can actually see it invading vessels in the specimen as well. And that has an intermediate prognosis. And then the worst subtype for follicular thyroid carcinoma is widely invasive. And that's where it's essentially the capsule's either been obliterated or largely lost, and the tumour is widely invasive throughout the thyroid, and that may even be well beyond the thyroid into muscles and other structures. And that's the one that has the worst prognosis of the follicular subtypes.
Do you see many medullary thyroid or the other subvariants?
Yes, we do. Yes, we do. So I report a lot of thyroid carcinomas. I see medullary probably a few times a year. That's probably about the right incidence for the number that we report. We see oncocytic carcinomas, which are another subtype, used to be under follicular, but they've now got their own subtype because they're recognised to have their own features and prognosis. And anaplastic, which I mentioned earlier as in one of the questions earlier, is very rare, thankfully, and has a extremely poor prognosis, a very rapidly progressive, highly invasive tumour that usually ends up with 3 to 6 months survival at best.
Is anaplastic the same as undifferentiated? Because they seem to be used interchangeably, but I'm not sure if it's a different diagnosis.
Now you're testing me here. Undifferentiated follicular carcinoma is it is sort of used interchangeably. My understanding is that it's not necessarily exactly the same. Undifferentiated is not a category I tend to use. Right. Anaplastic is the category that I use. It's in the WHO as anaplastic, and it has specific characteristics in that it has to look undifferentiated. And I think that's why the terminology is probably used interchangeably. Yeah.
Now, we have mentioned medullary as you see it a few times. Does this automatically make you think of familial cancer syndromes when you see it?
Yes, absolutely. So a reasonable percentage, about 25% of medullary carcinomas are associated with germline RET, R-E-T, mutations, and that's associated with the multiple endocrine neoplasia syndrome. So MEN2 in particular is associated with medullary carcinomas. So yes, if we see medullary, we would always make a comment about its high association with MEN2, and the clinicians would usually go on to refer to a familial cancer clinic for those patients to get counselling about whether or not they want germline testing.
Now, in cytology, we mentioned molecular markers. This seemed to be almost to assist with diagnosis. Is there any molecular markers we use from a histological perspective for treatment, or is it mainly diagnostic purposes?
I think that's actually a rising phenomenon. So there are molecular things you can do for the histo specimens. Some people probably do them more often routinely than others, and it often comes down to whether or not they're requested by the oncologist after they've been reported. So I personally don't routinely do molecular on histology specimens. There are some pathologists that are probably moving that way, initiating those tests, but usually we find if the oncologists are interested, they'll ask us. So follicular carcinoma is known to have prognostic implications if they have a TERT promoter mutation, TERT promoter mutation. There are also implications for responses to therapy in papillary carcinoma if they have BRAF and or TERT promoter mutations. We mentioned RET in medullary. And then in anaplastic carcinoma, there's about 6 that are listed as being potentially prognostic or therapeutic implications. So there are markers out there, but as I said, I think it's a rising phenomenon into how often we order them.
Now, just for going right back to the basics, can you explain how, because every cancer seems to come across it, where we have the TNM staging. Can you tell us how that fits into everything?
Yeah, so the TNM staging is a standardised system for reporting pathological stages of malignancy at diagnosis. It's a staging system produced by the American Joint Council on Cancer, the AJCC. It's used basically for any cancer that we diagnose. There's a small number of exceptions, but the vast majority would use this system. It's a very eloquent system because it takes into account qualities of the tumour, which is T, qualities of the nodes, which is N, and then M for metastasis. So it will look at the tumour, and it depends on what system you're looking at as to which qualities you look at, but it will look at the tumour and it will give a series of numbers, or if you like, categories according to qualities of the tumour. So, for example, if we go off topic, colorectal cancer, it looks at how deeply it invades. For a breast cancer, it looks at how big it is. Okay, so different qualities, but qualities about the tumour. It will then look at whether or not nodes are involved, how many are involved, what basins are involved, and then whether or not metastases are present. And so we take each of those categories and we score a number according to the staging system. There's a very large book that we use to do that. And at the end, we produce a pathological stage, so a PTNM stage. The clinicians are extremely interested in the stage. They always want to know, because that will then also help them clinically stage the patient in combination with clinical and radiologic features. and then that guides treatment and follow-up.
One question I'm always asked, and I'm interested in your version of this, what is the difference between stage and grade?
Oh, big difference. So stage is about as far as I'm concerned, is about the behaviour of the tumour at the time we see it. So it's telling me what it might behave like, but it's also telling me what it's already done. So if it's a deeply invasive colorectal cancer and it's already invading 10 nodes and there's a liver metastasis, then this is already telling me it's behaved badly. Grade, on the other hand, is something we assign. We usually assign it on a fairly simple system. It's usually either low or high grade, or low, intermediate or high grade, or grade 1, 2, 3. It's a much simpler system usually. And I think from my point of view, that's telling me about how the cancer might behave. So if I see a tumour that is low stage, so it's not very deeply invasive or not very large, but it's high grade, that tells me that it might behave in a bad way, even though it hasn't already behaved in a bad way. So I think grade infers how it might behave, and stage is telling you what it's already done.
We've talked a lot about malignant thyroid specimens coming through. Do we get many benign thyroid specimens coming through?
Yes, I would say the majority of the ones that I report are actually benign. And they usually fit into this follicular neoplasm or suspicious for follicular neoplasm category. It comes down to that, as I said, that issue of histology being the final definer for whether or not something's malignant. So the vast majority of what I report will actually be either benign adenoma or a dominant nodule in a multinodular goiter. So for some reason on radiology and clinical, there's some concerning features. The FNA isn't giving a clear benign or malignant diagnosis, and then the clinician essentially has no choice but to remove it. So the vast majority actually are benign. We also often see thyroiditis. So many of these patients also have a thyroiditis, either Hashimoto's or thyroiditis or Graves' disease. And so we'll see inflammatory cells as well. We sometimes find incidental things too. Parathyroids might be accidentally included, for example. So there are several benign features that we will see in these. And as I said, the vast majority actually end up being reported as dominant nodules or benign colloid nodules in the multinodular goiter.
Tiffany, are there any final thoughts or advice for doctors or patients?
Look, I thought long and hard about this. I don't think I do have any. Apart from to say that we've got very good systems in place to ensure that the report you get back is accurate and well considered, and we hope that they're useful. And if they've got questions, then they should be asking them.
All right. And also, should I enter medicine, I think histopathology is what I want to do, because you've got so many nice, clear definitions and structures, Tiffany. I'd feel safe there.
Yes. Well, that's, I think, why we're all here. We're a little bit obsessive compulsive, most of us.
Dr. Tiffany Symes, thank you so much for being part of This Medical Life.
No worries. Thanks for having me.
Dr. Rachael Chambers is a histopathologist at Sullivan Nicolaides Pathology in Brisbane. Her main areas of work are gastrointestinal pathology, endocrine pathology, and neuropathology. Dr. Chambers undertakes cytopathology investigations with a focus on thyroid, pancreatic and GIT specimens, and also provides consultation, second opinions in GIT, endocrine and neuropathology. She also has an interest in molecular pathology. Dr. Chambers currently chairs the Sonic Molecular Craft Group and is undertaking the NPAC extension to scope in molecular pathology. Rachael's our guest on This Medical Life podcast. Rachael, welcome.
Thank you very much.
Rachael, we're discussing thyroid lumps and nodules in this episode, but we want to focus specifically on molecular testing. How common is molecular testing for thyroid nodules here in Australia?
There are two main scenarios in Australia where we might do molecular testing on a thyroid nodule. The first is in thyroid cancer. And often those patients will have comprehensive testing done, particularly if they've got advanced or aggressive disease. The second scenario is where you have a patient who has a thyroid nodule and they have a fine needle aspirate or an ultrasound assessment and then a fine needle aspirate assessment with cytology, and the result comes back as indeterminate. So it's not benign, it's not malignant, but it's somewhere in between. And in that scenario, we can do molecular testing to try and better categorise that result into either a benign or a more specific risk of malignancy type result.
What is the best use of molecular testing for these nodules? Is this part of the diagnostic workup? Is this part of management, or is this a prognostic tool as well?
So all of the above. Yeah. So comprehensive genomic profiling provides information that contributes to the diagnosis, definitely, and specifically in those indeterminate nodules, it's very helpful to direct us onto our diagnostic pathway. But the results do also influence treatment. So the specific molecular genotype of the nodule or the tumour tells us more about how that cancer is likely to act or how that lesion is likely to act, what sort of progression they're likely to expect and how aggressive it might be. And then also with the advent of targeted therapies, we can identify potential targets for, say, checkpoint inhibitor drugs or the monoclonal antibody drugs, which are now becoming more widely available.
Now, what sample are we talking about? Is this something that has to be specifically known at the time when you're actually taking out the thyroid sort of fluid, or is this something that you can do a bit later as well?
The beautiful thing about this test, or I think one of the beautiful things about this test, is that this testing can be performed on any smear sample from a FNA, like routine cytology sample. Pathology labs tend to keep cytology samples for 10 years, and they have done testing on these sort of samples up to 10 years old, and they have got valid results. Generally speaking, you would tend to try and test within 2 years, but there's no... You don't have to decide at the time of fine needle aspirate that you want this testing done. You can make that decision later on down the track.
The test that we came across when I was studying this it's called, I think, Thyroseq. Now, when our listeners won't see that word, but it's written Thyroseq. Am I saying that correctly?
Yeah, that's right. It's abbreviated thyroid sequencing. It is a comprehensive genomic profiling test. So what they do is they get the cytology slide, or in America they take a separate pass and put it into special fluid. They either scrape the cells or put the fluid through their lab, and they extract DNA and RNA. This is then put into their sequencing machine, and they get a lot of information, which is then run through a really specific algorithm that they've developed to give the genetic pathologist information about the lesion. And then that genetic pathologist gives us a report to tell us what the likely outcome is for the patient.
What are some of the common genes that doctors might be familiar with that are being tested?
There are lots of genes associated with thyroid cancer. The more common ones tend to be BRAF and RAS. So the classification of thyroid cancer goes down sort of two main pathways for the differentiated cancer. So we have the lesions that look papillary or have a branch-like architecture, and lesions that look follicular, so they have a similar morphology to normal thyroid tissue. And lesions with papillary architecture tend to have BRAF variants, and lesions with follicular architecture tend to have RAS variants. So those are the two sort of main beginning points that we look at. And then there are other variants that you can see that indicate a worse prognosis, so things like TP53 and TERT promoter mutations. And if they see those type of mutations present, then they would be classifying the lesion as more likely to be malignant. They also look at tumour mutational burden and gene expression profiling. It's an amazing test because they look at the RNA as well as the DNA, so they can assess fusions as well, which is very important for thyroid cancer because we see a lot of fusion-based mutations, which has been difficult to test for with their standard next-gen sequencing.
My understanding is the Thyroseq tests 112 thyroid genes. And again, I wasn't familiar coming across, and I work in this field in pathology. So if GPs or other doctors who are not in the field, how are they able to make sense of the results that would come through?
So this is another beautiful thing about this test. The reports are incredibly clear. The two people who designed this test are Professor Yuri Nikiforov and Marina Nikiforova, who are a couple, and they're both genetic pathologists. They're originally from Belarus, and they actually used to live about 200 kilometres from the site of the Chernobyl nuclear disaster. So they had a lot of experience with thyroid cancer early in their careers. And when the USSR was collapsed or disassembled, they moved to America in 92 and qualified as molecular pathologists and started to develop this test. So it's been over sort of 20 years in the making. Marina particularly is one of the doyens of molecular pathology. She's the final author on many of the papers that are utilised to classify molecular results. And I think they're very passionate about making sure that everybody can understand the result that they're getting out of all of this complex data. So the reports have your patient details, and then they have a very clear box that is red or green for positive or negative. If it is a positive result, they then go on to specify what the likely risk of malignancy of that lesion is. And underneath, they then also spell out the specific variants that are available and a lot more information if you're interested. But just from the point of view of patients who might not have a lot of experience in that area, it definitely spells out the answer at the top of the report.
How much are you doing in your normal practice and work for just routine?
It's pretty variable. For cytology, we just have we have Thyroid testing available. We also sometimes do short panel testing for thyroid lesions, so just looking at BRAF and RAS. In histology, which is the other area that I work in, we utilise immunohistochemistry for molecular testing. So we look at BRAF V600E, one specific variant. We can look for the protein produced by that variant. We can also look for NTRK fusions via immunohistochemistry and NRAS Q61L. There is also comprehensive panel testing available for aggressive disease through the large panel testing that we do. At the moment, we're involved with the CASP trial. So we utilise the Avenio comprehensive test, and the private alternative to that is the Foundation 1 test. So from a cytology point of view, this is a new test. People are becoming more interested as they become more aware. We might send off up to 5 a week.
Looking at the other side, is there any chance of false positives or false negatives with this test?
Yeah, so the beauty of this test being developed over such a long time is that there's a lot of literature associated with it. They've recently published a review of 50,000 samples that they took with correlation. We look at 2 different variables when we're looking at false positives and false negatives, which is the negative predictive value and the positive predictive value. This is a rule-out test in that we're hoping to identify all of the negatives because the positives are so variable. You can have lots of different types of positives, but we want to identify the negatives, and the negative predictive value for this test is 97%, which means that 97% of the time, if you have a negative result, you have a negative lesion. And that is the same as a benign result on cytology. So when you get a fine needle aspirate biopsy and you get a benign result back from your pathologist, the risk of having a malignancy is the same as if you have a negative on your Thyroid test. So it is variable for other nodules. They have identified certain subgroups where it's even better. So for Hürthle cell or oncocytic lesions, which can be tricky to identify because they have copy number variations. So their negative predictive value on their published literature is 100%. So they've never had a false negative.
Is this test covered by Medicare or likely to be covered by Medicare?
Look, we're hoping that at some point it will be covered by Medicare. It's not currently covered by Medicare. It's a test that's routinely performed in the US. So every thyroid FNA gets a Thyroid as well as a cytology result. And the test is also covered or performed relatively frequently in Canada. And in Canada, it is covered by the government, but for more specific group. So if you have a benign lesion, then they won't do the thyroseek testing. If they have an indeterminate lesion, then they will. And I think that would be appropriate in Australia. If you're going to have surgery anyway, there are some reasons why it would be useful to have the molecular assessment beforehand, but it's not sort of strictly necessary. Whereas if you're trying to make a choice between doing an operation and not, I think that this information is really helpful.
Do you see molecular testing become the standard of care in the future?
Yeah, definitely. I think the combination of the cytology result with the molecular testing is giving us the most information and thus allowing us to get the best possible outcomes for our patients. It is incredible that they can get all this information out of so little material. You only need 300 cells on a slide to do the full comprehensive panel, which I just find incredible. And the beautiful thing about having it taken from the cytology smear slides is I can actually see the cells that they are sequencing before they sequence them. It's not a blind pass at an FNA into fluid where you don't really know what they're looking at. You actually are sequencing the specific cells that you're worried about. I find sometimes we get negative results come back and they do identify variants or genetic changes, but the variants are associated with hyperplastic nodules or genes associated with hyperfunctioning thyroid nodules. And it's very reassuring for me as a pathologist to see that, because I can see this clonal proliferation of cells and I'm worried about it because usually a clonal proliferation of cells is a neoplasm. But by being able to see that benign variant come back, I can know that that's what I'm seeing. It's representative. And yeah, it's great from a certainty point of view, and just an ancillary test that's really helping pathologists make better decisions for the patients.
Wow, thank you, Rachael. You've given us a front row seat to this type of work. Is there any final advice or any thoughts you might have for doctors or patients listening in?
Look, I think it's a very exciting time in medicine and in molecular pathology. I have been fortunate to spend some time with the Nicolaides, and I'm just so impressed with their passion for helping people with thyroid cancer and their generosity with their time and expertise. I think it's very important that our patients are able to have access to this sort of testing. It is standard of care in other countries, and I know we're a long way from other countries, but I think that it's very important that our patients, are able to have the best information to enable their outcomes. It can be very challenging to work out how to incorporate new tests into our traditional diagnostic and treatment pathways. And I think that we're very fortunate to be able to benefit from the experience of other countries who've been doing this testing for a longer time. I'm very passionate about thyroid molecular pathology, and a lot of other genetic pathologists and anatomical pathologists are as well. And I just encourage anyone who is thinking about it or have questions to reach out. The Sonic Genetics website has a specific page dedicated to Thyroseek, and the Thyroseek International website is just full of incredible information. They have patient-directed pages as well as doctor-directed pages, so I found that really helpful.
We'll make sure Dr. Travis Brown puts links to those in the show notes. Dr. Rachael Chambers, thank you so much for joining This Medical Life.
Perfect. Thank you very much.
We return now with Professor Yuri Nikiforov, who is the Director of the Division of Molecular Anatomic Pathology at the University of Pittsburgh School of Medicine and developer of Thyroseek Next Generation Sequencing Test for Thyroid Nodules. Yuri, let's start with the key question. How does Thyroseek work?
Thyroseek is a molecular test that with the main applications to thyroid nodules with unclear diagnosis. So patient palpate or physician palpate on an imaging is found to have a nodule within the thyroid gland. They usually come to a physician office, and the physician does ultrasound imaging, and if the nodule meets some criteria for possibly being tumorous, they stick a needle and send cells to cytology lab for a cytological evaluation, microscopic evaluation. And in about 60 to 70%, it comes back as benign. So no worries, it's a benign nodule. In about 3-5%, it comes back as a malignant. Okay, this malignant patient needs to go for surgery. And in about 25-30%, it comes back with the so-called indeterminate diagnosis. It means the characteristic of cells are such that you cannot, pathologist or cytologist cannot say if this is benign or malignant. And historically, these patients, most of these patients, were offered surgery and they, underwent surgery. And on surgery, and this is a national, international, around the world statistics, about 70% of them were benign and about 30% were cancers. So we have been doing 70% of thyroid surgeries on these nodules were done because we could not diagnose cancer in this nodule, because we were not sure. We were removing benign nodules because we were not sure if they're benign or not. This was a very, very clear. I mean, you don't need to be a genius to see that this is a very big problem in patient care. But it was easy, with silly arguments. Thyroid, this is just thyroid surgery. It's not a big deal. It's it's not very expensive. Why don't we just remove? Over the years, I mean, we did a lot of terrible things. We were removing appendixes, in everyone just to prevent. Who knows, maybe one of you develop, appendicitis, so on and so forth. In any case, that was the situation. So the idea is, can we get better? And I can tell you that the resolution of cytology is maximized. So it's not that the good cytologist can triage all nodules. No, it's just intrinsic limitation of the cytological evaluation. It needed to be something else. It should be something beyond that just cytology. And that was a time when I did 4 years. Before validating my medical degree in the United States, I did 4 years of genetic research in a lab of a very, very famous thyroid endocrinologist and geneticist. And I learned a lot about it, and I thought, why can't we use genes and genetic alterations to predict if this is cancer or benign? And that, in the essence, is what a Thyroseq test. Thyroseq is, we take cells that were collected from that, by the needle from the nodule, and we now isolate nucleic acids, and we run analysis for 112 genes, for all genes that can be altered, broken in thyroid cancer. And if we identify specific alterations, we say it's most likely cancer. If we don't identify, we say it's most likely benign.
Have you conducted any clinical trials using this technology?
Of course. I mean, nowadays you cannot convince clinicians to use anything without really solid data. So there was a number of it, obviously, like for tests like this, which is now very widely used. It was a long history. I can tell you the first very minute version of this test we launched in 2007, which was only 7 gene panel. That was minute really. And now we have 112 gene. But what I'm saying, there were multiple studies, but this current version, the most updated version of the test, we call it Thyroseq version 3. We ran a multi-center prospective, by the way, international study that included 9 centers in the United States and 1 abroad in Singapore. At least it's a little bit closer to Australia, So they also contributed some of the patients. And by the results of the study allowed us to demonstrate the performance of this test and how this test helps patients to avoid unnecessary surgeries, or in opposite, make the optimal first surgery if they have cancer.
Looking at the sensitivity and specificity, do you have any sort of idea about where that sits?
There are very specific numbers, 94% sensitivity, 82% specificity. But I can tell you that to understand what it means, it's better to use negative and positive predictive value. Okay, in an average practice with how these patients are sort of diagnosed with a typical diagnostic flaw, negative predictive value of this test is 97%, which means that the residual probability of cancer in this nodule is 3%. And I can tell you that it is low. It is low. It's not zero, but nothing in medicine is zero. Sometimes the needle goes to a different nodule, to not enough cells. And so actually 97% actually is very good. So now when we issue a report and we say that the test is negative, and we say that the probability of cancer is less than 3%. So that's if it's negative. If it's positive, it's 66%. And you can ask, wait a second, it sounds not very high, but I explained to you that thyroid cancer, like many, many other cancer types, is a multi-step process. It develops through multiple steps. So 66% is the prediction of cancer, so the cancer. But many of the remaining 34%, they're actually precancerous lesions. These lesions that they already have alterations, they're on its way to cancer. So it seemingly 66 is low, but in reality is much higher if you would take cancer and precancer lesions.
So at the moment, this is a full fee paying service in Australia. It's probably, fingers crossed, hopefully going to be moving towards probably standard of care, to be honest, given the amount of useful data that comes out. What status is it in the United States with thyroid nodules?
In the United States is a part of the standard of care. It is part of the standard, and I want to say, in the spirit of full disclosure, that Thyroid is not the only molecular test present in the US market, but this is a totally, routine patient care. And now I can tell not only in the United States, even in other areas, and I give you an example, is the Quebec province of Canada, which is the sort of provincial or government type healthcare, I believe very similar to Australia. They run multiple trials, sponsored by the government to see is it cost effective. And there was a recent study just published a few months ago showing that that saves $1 million to the government to offer this test. You have to be careful. You have to know how to use it. You apply it only when it's really needed. But it's a big saving. And big saving, it's very easy to explain big saving. Why? Because you eliminate 70% of surgeries with the cost, with the complications, with the staying in the hospital stay, and so on and so forth by using this test.
So if we look at our genetics of the different cancers, can you actually tell the difference mutation-wise between like papillary thyroid cancer, follicular, medullary, and anaplastic? Can it give that kind of data?
Let's start from the end. So medullary carcinoma has a totally different molecular profiles. By the way, it's also sometimes more difficult to diagnose using cytology. Is with the modern molecular tools become very trivial. Anaplastic thyroid carcinoma also has usually multiple mutations. It's sort of different. Papillary and follicular carcinoma, these are two most common types of thyroid cancer. What is interesting? The genetics tells us that this classification is not even correct, that papillary and follicular carcinoma have to be put together and split in totally different way, not into papillary and follicular, but into BRAF-like and RAS-like tumors. And this is the future. That's where we are going. Very soon, we are not going to say it's papillary or follicular. We are going to say it's a BRAF-like tumor or RAS-like tumor. Okay, so for them, genetics is very important, not only to diagnose, but also to predict how this cancer behaves. It's also predict how aggressive this cancer will be. So one of the big advantage of the modern science, and that is now sort of applied for patient care, I said, one for 70%, is just to say you don't need surgery at all. You can live your normal life. Your chance to develop cancer is very low. But also for the rest, 30%, it's not one size fits all. You all have to go for surgery. But we can tell, look, you have a cancer, but this cancer is very low risk. You can just have one lobe of thyroid removed, and your chances to develop complications is less than 1%. And other people, we can say that, you know what, you have only one CM nodule, but this nodule has already so many mutations that it's really bad. You can die from this nodule. So you need to have a total thyroidectomy, and you need to have radioactive iodine, because you are one of the very, very small proportion of these cancers that really already on its path to be a bad player. This is another impact and another sort of help that genetic testing can give to clinicians to better, most optimally treat and do not overtreat many of the patients with the diagnosis of cancer.
One of the aspects also says you can assess the risk of cancer recurrence. Is that in the same molecular pathway, is it?
We are very proud that from the very beginning, when we created this test and built it, we immediately, from the very beginning, we wanted it to address all three sort of needs, all three, to diagnostic need, prognostic need, and therapeutic, to predict if it has targets for therapy. And later, and some other tests, they addressed only one, let's say, diagnostic, and only now they're catching up. But we, again, I want to stress that we are very proud because our test is diagnostic and prognostic from the very beginning. You don't need to run additional panel. You don't need to do it again. The test gives you information on diagnosis and on cancer risk or on cancer prognosis.
Is there any targeted therapies for thyroid cancer available in the US?
Yes, there are several. I want to say that fortunately for thyroid, most of thyroid cancer is not aggressive cancer. And in patients, I have no need for targeted therapies. But over the last 5-7 years, this area is also explosion of knowledge and actually clinical application of targeted therapies. Now we have very good, very specific low toxicity inhibitors for thyroid cancers that carry NTRK fusions, carry RET fusions, RET mutations in medullary carcinoma. And maybe the most fascinating is phonoaplastic thyroid carcinoma, which is one of the deadliest tumor known to humans. Very, very bad. Very rare, but very bad. We have now really very exciting combination of dabrafenib and trametinib, two drugs that really, but they only work for BRAF positive anaplastic carcinoma. So if we identify BRAF anaplastic carcinoma, patients immediately should be put on that therapy. And obviously all of these markers, they are on ThyroSeq panel. This is the third application. It's diagnostic, prognostic, and therapeutic. Everything is in one test.
Cancer genetics, when you start reading about it in different organ systems, actually comes up, like BRAF and KRAS and everything like that I've heard about in colorectal. Is there much difference between thyroid cancer and other cancers? Is this almost applicable to other cancers?
I consider myself a very lucky guy because I've seen all cancer genetics basically in front of my eyes. I came to the United States in 1993 and I saw the first genes, P53 and RAS, and now I see, this all enormous impact that it gives it has on patients. So for the first maybe 10 years of cancer genetics, we actually, when our knowledge were very, very little, we actually thought that each cancer has different type of mutation, okay? That it has very specific. And then the more we know, the more we realize that it's not true. That you can find BRAF mutation in thyroid, you can find it in melanoma, you can find it in leukemia, you can find it in colorectal cancer. So it's the same mutation, but in different cell environment that would lead to a different cancer type and even biological behavior of cancer.
Wow, what a journey. Yuri, are there any final thoughts or advice that you have for doctors and or patients listening to this talk?
Perhaps I can say that you need to, when the diagnosis is not clear, now there are a lot of modern tools. Look around, read, try to see, because again, we are living in a very different time, very exciting time. There are new tools that can help. Try avoid making a medical decision, patient management decision based on unclear diagnosis. Because again, we have now a lot of tools in our arsenal that can help us. And even for treatment, I want to say that unfortunately some cancers, some cancers are very rare and it's difficult to treat, but try to sort of consult with other specialties, try to find some possible alternative ways, because there is truly a lot of new modern diagnostic tools and more new sort of cutting edge, recently introduced therapies that can make huge difference in patients' lives.
Thank you so much. I actually have to ask one last question. Knowing what we know now from your experience, from all the studies since, if there were to be another nuclear accident, perhaps at a reactor, will it be impossible for a government to be so quiet as it was back around Chernobyl? Have we moved past that? Will we be okay for all future accidents to move quickly?
Sadly, I don't think so. I don't think we know much more, but looking at certain regions in the world right now, what's happening, and looking at the access of people to information and their trust in government, unfortunately, we know much more. We would not be caught off guard as much as we had before. But unfortunately, I don't think that we have a comprehensive solution and everybody on the same page. What should we do with people living around in order to prevent this terrible consequence?
Professor Yuri Nikiforov, thank you so much for joining us on This Medical Life.
Thank you for having me.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is @Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/in/TheRealSteveDavis. This has been a PathNotes Proprietary Limited production.